One of the first questions I would ask is this, and we have a world expert in training on the robot, is this a training issue? Because just kind of looking at the stage, a lot of the people who are staying with kind of advanced laparoscopic distal pancreatectomies, trained in an area where laparoscopy was really your only option. And now we've had the robot for the last several years, and we definitely are seeing people swing that way. Is it easier to train people on the robot?
Yeah, I definitely think it is, but I haven't ever trained anyone for laparoscopic HPB surgeons, although I'm trying to in the Netherlands. But I think that one of the points about the ports is a lot of people do criticize that we use an extra port or two for robotic. But I think an important thing to mention at Pittsburgh, about 90% of our distals are done by our fellows or our residents. I think that it's very rare that we get to do them ourselves more. If there's an Applebee and the fellow's not advanced enough, we'll do that. But I think that if we were to do these all ourselves, we probably wouldn't need an assistant at all on the robot, or just one for suctioning and helping with stapling. But I definitely think that the setup that we have is really geared towards teaching our fellows. We have 5 SSO fellows per year, 2 HPB fellows a year, 7 chief residents a year, and so every month we've got a new people coming through. So all of our video library and everything is sort of focused on the steps of the operation. The sort of step 1 is all the mobilization part, the step 2 is all the transection part, and 3 is all the retroperitoneal part. So it really allows for a deliberate integration. Okay, this is your first one, you could do step 1 and step 3, watch the anatomy, see how we do step 2, and it kind of lends itself easier to training. However, that being said, that's sort of what I do. So the other side of the curtain, I don't know.
Matt, how do you approach training with your?
So I part of the reason I like the robot is it is nice to train with. But I think you want to train both laparoscopy and robotic. That is my preferred. So I think they are nuanced differences, and I certainly do more laparoscopic than robotic, but I do think there are advantages to certain specific cases.
I was going to say, could you outline what you think the specific limitations of a robot or the specific limitations of laparoscopy are?
I think laparoscopy in general, as I like it as a 2-person operation. I think it flows very nicely. I think there's a lot of synergy in how you operate together. To me, robotics is more of a 1-person operation, and I like it for spleen preservation for sure. It forces me to go slower. That's probably the best thing about it. I certainly do spleen preservation with laparoscopy, but if I'm planning something, I think it's a great tool to help train.
Okay. Dave, do you want to take that same question?
Yeah, I mean, similar answers to what Matt gave, and I'll add on the laparoscopy 2-person operation. If you have a trainee working with you, you get the sense if they have the right traction, counter traction, and can do so. They may start off by taking the short gastrics and start mobilizing underneath the pancreas, but if they're not quite there yet for the vessel dissection, then you can take over for that back and forth. With the robot, then yeah, you can hand the controls over or not, so it's a little bit easier to flip back and forth instead of having to change sides of the table, but I think both are necessary.
So I'm sure this never happens in Pittsburgh, but what do you do in an emergency? Have you ever had you're taking the celiac and your whatever blows off and you're suddenly dealing with it and you've got the robot between you and your patient?
So so taking these operations, the Applebees are done with 2 attendings. We have not had one case which was done by one of us alone. So there's 2 attendings in the room, and the reasons are exactly what you're saying now. So if you get into trouble along the SMA, the renal vein, you really need someone at the bedside to be able to grab quickly and put in needle drivers, throw in the suture, be able to man the suction at the same time. So that is a disadvantage in terms of the big operations. But for the distals, I think, as Melissa was saying, probably 95% of them are done with 1 attending and a trainee. But a challenging Whipple or a challenging operation in Applebee definitely needs 2 attendings. I would not advise doing it without someone, an expert pancreatic surgeon, or at least an expert laparoscopic surgeon at the bedside. But having said that, we have not had any conversions in our series of 30 Applebees. So this is something that's probably going to bear out in the next few years. Laparoscopy may be associated with a higher rate of conversions. We've certainly seen that in the NISQIP data set. and we're publishing on that soon. Just robotics allows you, if you have a good bedside assistant in such an emergency, it allows you the dexterity to sew um, and control bleeding better. If you're not Mike Kendrick or John Stauffer.
I was going to say,
anything.
so I've actually,
yeah, yeah.
I've actually just, I've been and watched Mike, and Mike's used both the robot and actually I went and watched him do 2 Whipples in a day, one with the robot and one without, and so you're kind of a good person to comment on this. And I know that you're leaning towards laparoscopy now. Why are you doing that?
Because when I use the robot, I have to take lots of protonics because it slows me down. Honestly, I think it just takes longer. It has nothing to do with the setup. It's just you got more arms in there. You've got an assistant running the scissors that's being pushed in the chest by the arms, and everything's just in slow motion for me, and I just can't take it. But honestly, I don't think there's a real big difference. I think if you can sew, I don't think there's really any advantage to the patient with the robot. But I do agree, and I think Dr. Walsh kind of hinted at that. I think if it helps the surgeon, that's great. And I don't think we should be embarrassed of that. If it helps more people be able to do those things, then that's the way it should be, because ultimately the patient's going to benefit if their surgeon can do it safer and better with the robot. So I don't have a problem with it. I just don't find it very helpful in my practice.
Yeah. John, do you have comments on it?
I think it's very similar to what Mike has just said. And to Amir's point, we almost never, maybe it's the male model, but we just never have 2 attending surgeons in at the same time almost for these advanced cases. And we don't really know what our assistants, the level of our assistants are going to be. So it's very difficult for me to pick the robotic choice for that reason alone almost.
Yeah. So you.
Yeah. So I mean, I think that's a good argument, but the question you have to ask yourself is, if you need to convert and you're having to convert more, and this is for probably not you two, but anyone in the audience. So the price is either you bring in another attending that can help you out, or convert to an open operation. I think I agree that the macho element is probably in there, but I think we also have to think about, staying minimally invasive. If you're planning to stay minimally invasive, I think the robot or having another surgeon for these complex cases may be, just for, again, not the entire procedure, but for the critical portion of the operation, may be worthwhile to stay minimally invasive.
So now we're finally getting to some debate.
Well, not so much of a debate, but what you haven't shown is that, are you converting less because of the robot, or are you converting less because you've got two surgeons there? At least for the Appleby, right? The ones where it really matters. I know you have some data that shows distal pancreatectomy, but I would argue the time period and the experience at that time was probably biasing that a little bit. So yeah, if everybody that did a laparoscopic distal had 2 consultants in the room, I bet you the conversion rate would be lower as well. If you had 2 trained hepatobiliary surgeons there. Either that or one of them would kill the other, I'm not sure.
Yeah, I think the way we've looked at this, I mean, like laparoscopy or ablation versus resection, and there's so many places, these are tools, and I think what the message I always want to try to pass to the audience is that you need to be comfortable with the set of tools that you have available to you, and that may be the one that's better for you. So.
Paul, can I ask a question? How many in the audience have unlimited access to the robot? You want to use a robot, you can book it. It's a pretty good number,
yeah.
but it's a heck of a lot less than 50% of you. And so part of it is, in order to have block time in my hospital, you've got to put in the time and actually use it. And if you don't use it, you lose it. So sometimes I'll do some stuff robotically because I think I'm going to get the same outcome, but I'll do it because that's how I maintain my block access.
Sure.
I think another point to make is that there's kind of a time and age related component to this. I think that as a fellow and as a resident, I did a lot of advanced laparoscopy, and as a fellow, I did a lot of advanced robotics. So as an attending in practice, I do about 90-95% robotic cases, and have never even done an open distal pancreatectomy. And I think that this is going to be sort of the future, as our residents are now, doing routine cases, always laparoscopic. I think their skills are going to get better. And then certainly coming up in the future, the same thing with robotic, that I think part of this is the implementation, of my senior people having not trained with laparoscopy and robotics, that there are people in the audience probably with that challenge where you didn't have that as a resident or as a fellow, and you're trying to adopt something new. So it's really, there's 2 kind of paradigms, people that are established hepatobiliary surgeon adding, you know, a technical platform that's different from what they've trained on, and, you know, training the current people on either platform. So I think in the future it'll be interesting to see this debate in 15 years, you know, when everyone's done a million, you know, laparoscopic suturing and a million, you know, robotic, you know, hernias, and then are doing this case. So I think you know, it's important to mention that sort of atmosphere.
Great points.